Committee. I am Councillor Lucy Mount, Chair of the Committee, and I will be chairing tonight's meeting. The event is being streamed on YouTube, and members of the public and the media are welcome to watch remotely as this discussion taking place. Now, I welcome all of you in Committee Room 1 and everyone watching on YouTube. Before we proceed with the meeting, I would ask everyone to please make sure your mobile phones are on silent and switched off, and we will start with a 72-second silence to remember those who lost their lives in the Grenfell tragedy. Starting with apologies of absence, I have received apologies of absence from Councillor Anne Sarum. I hope that Roberto. And we don't know about who. Moving on to declarations of interest. Does anyone have an interest with that? Minutes of the meeting held on the 18th of November. The minutes of the meeting have been submitted for confirmation, and the next ordinary meeting of the committee. Is everyone happy to present? Yes. Great. Moving on to agenda item 4, the budget proposal. This report sets out the savings and growth proposals for the adult social care and public health for the budget of 2025-2026. The committee is invited to review the proposal and consider whether it wishes to make any recommendations to the leadership team. Today we have Liz, Josh, and Anna, and Tom here today to speak to the report. Let me say first.
Thank you, Chair. So yes, I'd like to present our draft budget for adult social care and public health. This has been a journey that I've been on it and Liz since May this year. So it's been a very long and arduous journey to get to this point, trying to ensure that we have the best services available, frontline services, while also ensuring that the council remains balanced as well. Many people will see that around the country, many councils are going to the wall due to the spiraling expenses of adult social care. So much so that many are going to declare or about to declare bankruptcy due to that. We've been really diligent in saying that our costs are increasing, home care costs, people using the service increasing year on year. There are further demands and complexities, but also we need to live within our means at the same time. So what we presented in the paper today is about £1.25 million worth of savings for the next financial year, 25-26. And there is listed in Appendix 2, going specific detail on what we propose, and as I said, welcome the committee scrutiny and recommendations on those. But I've been really happy to work with Liz and Tom on this to get it in the best position that we can. There are tough decisions, but no decision, Chair and committee, will directly impact frontline services, which is a really important kind of limit test that I would like to achieve at the offices as well. So obviously, as you've seen, the budget's split into two halves. We've got a social care and a public health one. Public health one, that's not really so much so because it's going to basically the forecast and the expenditure are the same. But in terms of the other parts of the service, we've had to find money in order to ensure that the general fund is balanced and robust. But happy to take questions on those, so specifically Annex 2 list where we propose the savings, and happy to take any views on those.
Thank you very much, and thanks so much for coming. And I appreciate how difficult job is at the moment. So thank you. I think my first question is just to understand more on complex cases that are transitioning, and the 500,000 that's coming in here. So just to understand, is this a normal amount that would be usually coming in each year? And looking forward to the next years forwards, do we expect this amount of cases to be moving over? What can we be doing to future-proof it?
We've got Viz and I have gone through it numerous times. In fact, there was a lot of questions from the leadership team as well when we presented to them draft initially. Team's done a really good job in trying to estimate those year on year. Let Viz answer in more specific detail, but we do have kind of an idea of people going to transition next year, this year, and the year after, and so on. And we'll balance those in the well. Viz, you want to take specific on that?
Thank you, Josh. So, like Josh was saying, is we asked for 500,000 growth. The reason for that is we worked with children's services to identify any cases children moving into adults, so that means from 17 to 18. So obviously those cases or children will be transferred to the care of adult services. So that means that we will be taking over the funding. So it's quite straightforward. We went through that. We know how many children in children's services and how many are going to move 25, 26, 26, 27, because based on the age. Of course, there are some children moving outside that we wouldn't know. So based on that, we've done some analysis, and there are 6 children will be moving into adult services, and they will cost quite a lot of money. So that's about 436, something like that. So therefore, that 436 for that, and also we've also seen an increase in mental health referrals, etc. So altogether, around that figure of 500,000 for we asked for. And in addition to that, you will see in the report, we've seen an increase in complexities of older people, and also increase in, that means increase in home care hours, increase in residential placements, the new placements, when people sadly pass away and the new people coming in, and they are expensive, complex cases. Therefore, we spend quite a lot of money as well. So what we ask for 500,000, yes, that is.
I should correct the record, Chair. Appendix 2 is the growth. Appendix 3 is the savings. That's what I meant when I at the start.
So on that, you are aware, sort of say next year you're clear of.
Yes.
We are.
So I was really just questioning, is that not just almost the same every year? We sort of know that.
Yes.
So why is it a growth? Because we must have had the same last year.
Every year.
So we're getting more next year that there's a growth, or
every year it varies. Sometimes we have 4 children moving into it, and sometimes 6, sometimes 12. We don't know so each year is different. The budget stays with the children when they move into adults, and we will have to fund that. So therefore, we need that. So we ask for that growth each year. So for next year, you will see that estimated growth is for 500,000. We will then do a detailed work for 25, 26, 27. Ask and figure how much it's going to cost, additional cost to the adult social care.
Yes, if I may, Chair. On that point, to clarify that this is the 466, the 430, that is for these 6 children. You foresee it, you wouldn't need to ask for growth of another 430 million, 30,000 the year after.
Well, we don't know that figure, how much we'll be asking in 26 and 27. This growth is only for 25.
Yeah, so we don't, but as you say, we can look at the number of kids who are coming up.
Yeah, we know the rough numbers, but some of them become as continuing care, then they become as the responsibility of the NHS that we don't need to fund. So
Right.
we need to do a assessment nearer the time, so we will get the right figure for the 26.
But there's no, in the next, as you said, an imprecise science, but the next sort of 2, 3, 4 years, there's no cohort that is, say, 20, or there's nothing coming down the track that is particularly big that you can say.
Yeah, we know that numbers, that's what we asked for. You will say 26, 27, also 500,000, but that's sort of a approximate figure. And that if someone moves into RBKC as a child, that's enough, so that figure might pay, of course, someone.
And you're always in a position where you would receive that funding. It would never be that you were
Always, every year. we
Having-
get the funding.
okay. Fine. So that's
Yeah.
push it.
Thank you, Chair. I'm just quite concerned. How are you going to, 5.3, the mental health workload increase,
Yeah.
12%?
Yeah.
Considering there's a remodeling in the social care workforce, how are you going to cope? Section 75?
Section 75.
Yeah. How are you going to cope with that great demand and increase if you're going to be remodeling your workload?
Workload, yes. So, so we restructured the service based on the Section 75, coming out of Section 75 with the CNWR. Now we have a memorandum of understanding with them. There are some benefits to the council that we managed to reduce the management cost. So therefore we're able to put the money into with frontline staff so that we can manage the demand. This 34K roughly is an additional amount we think we will need for 25-26 to manage the demand. So we will be able to manage with that amount, and the savings we achieved through that Section 75, that gave us an opportunity to restructure the service, and that is working really well at the moment. So we will be able to manage the demand with this money coming in.
And would you be able to employ more staff as a result of the high increase?
We have, what we've done is that we reduce the management cost and reinvest that into frontline staff like outreach workers and social workers. We have a more sort of preventative model, what we have put in place last year also. So you will see that difference in service user outcomes in the near future. And we will, of course, we will do a review in a year's time to see how the Section 75 model is working, and then you learn from that to any changes needs to be made. We will make a change. This figure you asked for is kind of based on that need and the demand for services from the staff. So this is quite a great sort of forecast.
Okay, thank you.
Definitely. I have three questions. But my main question is on the capital program. So you have a $3 million, over $3 million to spend with the Kingsbridge Road.
Yeah.
So is there more capital program planned for next year? I mean, how do you anticipate that to weight into the future budget? I mean, this is for this year. Then going forward, is there any estimated of spend with that? Positions.
Yeah. So with Kingsbridge, the reason why it flags up like it does is also basically an in-year purchase, a one-off that happened in Kingsbridge in disrepair. NHS wanted to get rid of it quite quickly, and we had like literally 3 or 4 weeks to kind of do the whole transaction in. Now that the council owns Kingsbridge as a whole, we intend to, in due course, obviously we'll consult the Ward Councillor as well, which we haven't started the program yet, to refurbish kind of the work, you know, having flats and people with learning disabilities and things like that. For future years, there is also a view for further capital works as well. They're not in the pipeline yet because they're not yet designed or anything like that. But one of my big priorities is because I think capital works and adult social care in this council has been underinvested for probably about 10 years. I think children's services are really good at it. Environmental health has been very good in terms of environmental community has been very good at public squares and things, but not very good at adult social care. So Kingsbridge is one, and we're looking at other alternative sites as well that we could potentially use. So that includes St Helens Garden over in the Council of Access Ward. Again, no real plans right now, but trying to ensure that we can potentially put some people in there at some point. We also have other developments going on in the place as well. So obviously Maxilla, which I know the OSC looked at, and I know we're bringing back that to the OSC in February. That and potential other options. St Mark's Road. Again, not particularly a very, very poor building as it stands. What we would love to do on that, that's also another possibility. And we've also got the sites, Blocks Road in Chelsea, where we're looking to build 65 extra care units in due course. And then there's the two that the council doesn't own or run, which is at Earls Court and the potential Kensal Canal side as well. Whatever the developers say there, but we're really pushing them.
So Earls Court is development as well.
Yes, that's right. So we've asked Earls Court, again, nothing confirmed that for planning and everything, to make provision for adults with either learning disabilities or social care needs. And likewise with Kensal Canal side, again, pushing them as well to say, look, whatever you're going to build, and obviously that's for the council committee to determine if it's good or bad. But for our point of view, we're pushing as best we can to get adult provisions of that as well at the same time. So with Kingsbridge, yes, a slightly unusual one, which the light flags up, but overall that should not happen in future years.
Okay. I have my other question is on the outturn. So you benefited from the discharge fund, it's more than $1 million.
Yeah.
And the market sustainability improvement fund,
Yes.
about over $2 million. With the current government in place and obviously slightly different direction than what was anticipated, is it something you think you can replicate next year, or is it something that you think will change because it has a massive impact? Is it too soon to say?
You go, that's right.
I think we will get that funding.
Okay.
For the social care discharge money. There's two streams of money coming from, one from the government, the other one coming via the ICB.
Mm-hmm.
Because the interest of the hospitals, we have invested that money into the discharge rate. So we'll get this about 3.3 million. So we get about 1.8 from the DHSC and then 1.5 via the ICB.
Okay.
And also there's an announcement of 680 million additional money into the social care grant, but that's not specified for any discharges or anything. So that's also, but we don't know what sort of formula the government will use to give the money to the councils. Yeah, so for the time.
So that's December you're hearing. Is it?
Yes,
Yeah,
that's
that's just released. Yeah, it's the week beginning the 16th of December. The local government finance estimate will be published.
It should not affect us, affects the whole council.
No.
Funding period as well. That's one of the things that we're pushing. One concern that is a concern, and not being political here, is that the impact of the national insurance employees rise is going to impact our contract, all our commission services, because we contract them effectively. And where that extra percentage, especially with the lower threshold as well, is going to come from. We don't have answers right now for that. It could have a huge impact, which we're not budgeted for, either this or any of the full council's budget in general, what impact that will have. It could add anything from 3+ million as a, or 3+ for the council as a whole, which we were budgeted for. We don't have money for right now. So it's going to be a really challenging time to work that out. I know perhaps some other kind of groups will make a statement, and not the council, care groups, about the next rise, because it affects not just well, it doesn't affect the NHS, but it affects NHS commission services, GPs, charities, as well. So it affects everyone all over the board. But as it stands, council's not budgeted any impact on that yet, because we just don't know what the routes
And
and
what's the
exclusions are.
date when we'll, yeah, is that just?
Well, the
more
next
likely
change is
next year?
supposed to come in from the new financial year, so 6th of April.
Okay.
I don't think the next bill has passed Parliament yet, so that will be, see what happens in that. But in terms of that, we don't know. I don't know, Tom, you know, what we expect to hear. on
Well,
those
the government
commissions.
pledged to cover direct NIC costs, so council work.
Yes,
so
council work.
those costs will be covered, but hasn't mentioned any cover for indirect costs, which is all kind of commission services. And the 680 million social care grant has been announced. If there's no additional funding to cover NIC costs, in a large proportion of that would probably just be eaten up by the demands from the market to cover their NIC costs.
I think the issue is it is a huge issue for the providers, especially the small providers. Therefore, they didn't expect this. But it's not just for adult social care; it's also for any commission providers working for the council. They're not exempted, but council workers, like Tom was saying, that will get that money back from them, and that's announced in the last budget. But we don't know yet whether they will give exemption to those providers in critical services or essential services. But what we know through the ADAs is that the providers are lobbying for them to be exempted from the national insurance increase. So it's not just for adults, but it is an issue for our providers as well. So, and the other point on the social care grant is not for that national insurance. This is purely for social care spend. As I said earlier, that we've seen clear increase in number of people coming into services, complexities, people, the new services going into residential care, nursing care, live longer thanks to the medical advancement, etc. So the cost is going up and up. Not just for RBKC, it is an issue for all the councils. Like just was saying earlier, many councils reported overspend. We are one of the few in London has been managed to balance our books in the last, many years. But that's because of financial management. We've got so many systems and processes in place to monitor spend, wiring budgets, etc. If there's an overspend, then we find savings from another area to offset, etc.
And I think that's a testament to Tom and Viz and everyone else, because this council, unlike perhaps what people think, doesn't have any money in any other council. It's only due to our due diligence and management that we managed to keep our finances under good management. Because as the OSC will see, if those on the OSC, you'll see every breakdown from our reserves to our spend to everything else to say that we are no better than anyone else in terms of how much money this council can raise or raising fees. And the expenditure of that, there's just down to the testament of Viz and Tom that ensures that we are on top of this.
Thank you.
To ensure that we don't overspend or get pay for things that we can't afford effectively.
Can I just then give you good news on that? Because it's when you spend money, you need to look at the outcomes. Are we delivering outcomes? So I really want to talk to you about it. The RBKC is the third best in retention of adult social care, qualified social workers and OTs in London. So we are so proud. And London Now, in inner London, people still wants to work with us. Expensive to live here or expensive to travel, but it still wants to work. So that's something we're investing in learning and development, and we do everything we can to retain staff. And again, the voice survey done every year by the council and our RBN, sorry, the Health Social Care and Public Health is the top in the engagement. Councillor Hargraves was there, and you were hosting the event staff awards, and there were 9 awards, and we got 5 out of the 9 for leaders and various awards. We won the award. And again, on point, if you look at our, we capture quantitative, we call PI, performance indicators, which we have to do for the BHSE. And also, they also do a qualitative assessment, like they send out questionnaires to residents and ask them what they think of our services. So the direct payments we provide, we are 3rd best in London. So we have the highest number of people on direct payments. And if you look at the service users receiving annual reviews and assessment, we scored 96.5 compared to 60% average nationally. 96.3 carers have their assessment, annual assessment. So that means we're doing assessment in a timely fashion. 4.6 of adults with learning disabilities are in paid employment. England average is 4.8. And so I can go on to talk about various and the qualitative surveys. Carers were extremely satisfied with the support of service they received. RBKC is 38.1 and ranked as 7th best in London out of 33 authorities. So England is 36.7. So
Good stuff.
what do we? That's the money we spend and the outcomes. So I thought it would be useful to do that as well.
Right.
Thanks. Just a couple of quick ones. So point 3.3 mentions that some areas for underspending have come from temporary vacancies across the directorate, and I was just wondering if that's going to be the case for next year. It looks as though some of the things are repeating.
Yeah. So we got very strong, well-organized recruitment panel in place. It's not about gatekeeping, but it's about making sure we recruit more permanent staff. So because agency staff are expensive. So we've done that in the last year also. So we managed to save quite a lot of money for the agency staff, including how we recruited more permanent staff. And that helped to balance the books last year. And this year also, we think we will save some money. And also, you will see there is a savings also there for staffing, about 500,000, which we already identified. So this year, we've got staff savings of 256. I must say.
Sorry, what does that mean?
250K.
From unfilled posts?
From unfilled posts.
Right.
No redundancies, no disruption to service delivery. These are posts has been vacant for a long time, or we managed to get them on a agency to permanent contract. So that saves us a lot of money.
Okay. So it's not that we're not using agency, it's that we're asking that those agency staff are employed under sort of in-house rates.
So we are asking, of course, the when they become permanent is cheaper.
Sure. So you're saying that you could do. Sorry, the first question was about the staff vacancies and whether that those posts are still vacant for the coming year. So are we going to be making those same savings, or have those posts been filled?
Those savings, yes.
And are those posts therefore not needed?
Not needed. For example, if you identify a few posts, for example,
I guess I'm just trying to square that with what comes across repeatedly in the report is just the spikes in demand.
Yeah.
So I'm just trying, and then there's a question in Appendix 2 about the growth proposal about the social services customer service team and the importance of investing in that and ensuring, that it doesn't impact quality.
Yeah.
Because of the additional, stress on it. So I'm just, wondering how those positions can be safely eliminated.
Yeah. So some of them, so the customer service line is managed by the customer care. It's in a different direction, but they need staff, and we agree with them. So that's why we got them.
Okay, I'll come back to that.
For us, I'll give you two examples. One is the occupational therapy assessments. So we have social workers goes out and do the assessment. If we train them up to do something called trusted assessor, so that means we can provide the training and they can issue OT equipments, minor OT equipments, and those people don't need any full occupational therapy assessment. And that we had some posts like 0.35% full-time equivalent, and they've never been filled that post because you can't recruit for that, it's difficult. So that we train.
So you're just downgrading the bandings, basically, is what you're saying. So you're sort of down-skilling the individuals who are responsible for these.
I think it's the job for the right person in the right team. So, for example, the 0.35%, the full-time equivalent, we couldn't recruit. We haven't been able to recruit for years. But we think is that when you train up someone, a trusted assessor, and they can provide a timely service. So when they do a social work assessment, they also can do the trusted assessment and immediately recommend and issue that equipment for those people, so they will get it quickly.
It's just that they are referred to as temporary vacancies, not roles that have been reallocated. So the question was whether these temporary vacancies are going to be filled, or are they going to be eliminated, or is the saving going to, because you're saying that the same saving is going to be for next year, surely we'd want to be recruiting into those posts.
So
that's the line of questioning you'd have if it was a GP, GP commissioner or whatever that was sat here.
Yeah. So the temporary vacancies for the 250 for 24-25 we identified as they are not going to be filled, and they can be, we don't need to fill them. So that's including these people I'm talking about, these trusted assessors, etc. So some of the posts we don't need to fill them. So we will, there's no redundancy, but we don't need to fill them. So therefore that post will be there as a vacant post. So that's a saving for us.
But once it stays a vacant post, if it's not needed, I think that's the point. It's not temporary anymore, is it? It's just wiped off the.
And what assurance is there that actually these posts aren't needed?
Can I just add to Monica's point too, because one of the questions Anne sent me was the fact that she said when she was lead member, she wasn't allowed to make any staffing costs, and so she's concerned by how we're now making the staffing costs, which kind of adds to what's.
Yeah, I think it's all of these are carefully considered at the panel, and that panel look at a vacancy post and see whether do we need those posts or can we use them differently for the business need. So some of them has been vacant for a long time, so those posts will be reused for example, one example you'll see this 2 commissioning posts, and we thought we could merge them as one post slightly higher, and they can do they can fulfill the business requirement, and rather than having 2 posts. So it's about merging posts. It's also about redesigning the business process. It's also about looking at the task of that course supposed to do, and can we redesign or can we train up someone else to do that role, which is not something unique to RBKC. It is being done.
No, it's not. It happens in all services, because it's you just downskill essentially, and the role is fulfilled by somebody with less qualifications who costs less.
I think.
But is that always the case? Are we downskilling people? That's a worrying.
Well, we want to, obviously, the council's position is transformation, we want to transform, but to get the best and most efficient service that we can. Now, as we know here, all councillors, including myself, have no HR function whatsoever. That's in our constitution and that's in the legislation as well. So we have to rely on officers to give us that advice the best way we can. And I think what is proposed is probably the best way forward, just to make us more efficient. And we don't need the places. We don't need them. I mean,
But if you're saying something like an OT can go out and do by more training, can do an additional assessment while they're out, which saves a second. That's not downscaling. That's upskilling.
Yeah, that's what I'm trying to say.
No, that's not upskilling. It's upskilling of that particular individual,
Yeah.
but as a service overall, that is how efficiency savings are made.
But that doesn't necessarily mean downscaling, I don't think.
It just means that the most
Reskilling.
suitable qualified person for that role isn't the one fulfilling the role. It's
Yeah.
somebody who's had some, like a physician's assistant that you're saying instead of a doctor, for example.
Yeah, but in this case, I would say that our aim is to provide the right service at the right time, at the right place. So if someone needs a simple equipment, why do we need an OT assessment for taking another social worker goes into the assessment, come back to the office, write the referral, pass it to someone again goes and do the assessment. It's not necessary. If that person can do the trusted assessor, that is perfectly, in our professional view, is perfectly fine, rather than creating another bureaucratic process by referrals and another home visit.
I'm not saying the system can't be made more efficient, I mean, but that's a separate issue. Anyway, can I just ask a little bit about the savings proposal on page 14, the top one? Yeah. Could you just say a little bit, explain the very first one, continuation of prevention initiatives?
Yes, so we've been working on this in the last 4 years. So this was the saving for 23, 24 and 24, 25 and 25, 26 and it continues. This is about people providing those people who are receiving a care package at home with 2 visits to transfer someone from bed to chair, and that person slightly improves because we do review. And if they agree, we could provide a ceiling hoist. So therefore, we just need 1 person. So that is, we have made savings in the past, and we can continue to make savings. And we haven't received any complaints. This is not something it's not a compulsory proposal. It's about working with the people, and if they think they need their less intrusive care, we will provide that. And also, pressure relief mattress and those things, various, assisted technology also includes in there.
So I don't fully understand what you're going to have to sort of unpack it for me a little bit. Service uses annual reviews to increase the focus on helping people live more independently and achieve their outcomes. And that's a savings proposal. How I don't understand.
Okay,
so is it, the example that you gave is going to someone's home, realizing that they no longer need the equipment that.
Sorry. So what happens? So for example, someone is discharged from hospital with twice a day 2 carers to transfer someone. So you're talking about 6 carers, 3 visits. And then in 6 months, we do reviews. Social workers goes out in 6 weeks' time and also in a year's time. That was the statistics I was talking earlier. So when we go and do the review, social workers sit down with the family and explain how the care package is working, whether the person has slightly improved because it's changing of need all the time. If the person's needs have changed and they don't need that care package, of course we will agree and we will reduce. You don't want someone to walk into a house all the time. The key thing here is that if 2 carers going into someone's house and transferring someone from bed to chair is, in my view, and it's our view, social work view, is been intrusive. If they have the house which is suitable for a ceiling hoist, then we can provide the ceiling hoist. Then the one carer can transfer the person with the ceiling hoist, bed to chair, etc. So you don't need the care. So that's the saving.
And what proportion of the saving, is that something that's been implemented in this past year gone?
Yes.
Yeah,
Yes.
and so what sort of savings have been kind of achieved through that?
Mostly on the hoist and various equipments and assistive technology that, we can provide something which helps someone reduction in care. We can provide that. And also direct payments and various, those things. It's always, we have done this in the last few years. Every year we have achieved those savings. We haven't received any complaints because we work with the residents to just the care, which is we have to do it because you don't need those level of intrusive care in someone's life. So in my view, that is a good thing to do because it's an ongoing review.
Yeah, thank you.
I just no, this is not to do with the budget, but out of that conversation, are we in charge of wheelchairs in our budget? We're not.
No, we're
Who's
not.
in charge of
It's
wheelchairs?
NHS.
Okay, so you don't work alongside the NHS to deliver that
We
service?
can always help liaising with them
Okay.
and speak to the GPs or speak to the commissioners and that. But we don't hold the budget or we don't commission that service.
I'm just going to ask a couple more questions that Anne sent over. One is just regarding the public health reserves and are we doing anything innovative with this money and different? She's sort of concerned that it just gets used to fill.
Yeah, so we've actually looked at the whole public health budget this year that I've talked about with Anna, the Director of Public Health. So with something that is wrong, but we can't really hold that much money as a public health reserve. Otherwise, we have OHID, who's the regulator, come in and say you have to spend it. You're not allowed to hold reserves really in the public health reserve. And it was out, but that's kind of how it works. So what we've done this year is we've got two different kind of things. So we have established a kind of a public health board where the rest of the council can now come and bid for public health money. Now, public health money would need a public health outcome. So no one can't just go in and say, well, I want a new road, because that's not really, you would have to say, for example, teaching students outside with community gardeners. That's beneficial for everyone because you're learning about nature, you're learning about outdoors, you're doing some physical activity at the same time. So that's kind of how that would work. So at the moment, that's kind of what we do. And what we've done as the council as well, we've taken the decision this year to spend more of our public health money on trust-wide council services. So now we're probably top in the country doing that. Now OHID, who I said is basically the regulator, has a kind of recommendation. So you can only really spend 20 to 20% of your public health money on cross-council services. We've taken ours up to about 30%, which you can do, but that's the very, very top you can go. The only other places to do that is Westminster and Newark in the whole country. But we've done that as well. So what happens now, in order to get that money down, spend it in a way, the council portfolios across all different directorates, so all the 250 plus services we provide, will come into public health and say, I would like to bid for the money, and this is what I would like to do with it. And again, it has to have a public health outcome. I can't just be filling budget gaps on the side. We don't allow that, and plus public health money is not allowed to be used for that. And then the board will take a decision. So the board is Anna and Dan Hawthorne, who's Executive Director for Housing, will then take decisions on basically what is the best way to spend that money on in that respects. Public health is different in terms of it's got its own budget, its own system. Anna is responsible for its spending, so not me, but that's kind of how it works in legislation. So that's kind of the operation that we've done it on. So as I said, we've built kind of a better public health resilience this year with a better governance procedure in place. I said starting this financial year, as in 25, in order to get that money out the door and helping the best community as soon as possible in that way.
Okay.
Just to add also, I think cover points, and also we always need to keep some reserves in public health at certain amount. If you have a COVID type of thing, something happening, and we need some reserves.
So we can't just have a lot.
You're not going to balance it looks like adult social care. There's always going to be reserves, and how much is the question. That's why Anna will decide as a statutory director based on London PH or whatever, all the some kind of analysis based on that. And also, like Josh was saying, we are spending the reserves now. It will come down. And in fact, you can see here, we draw about 2.32 million to cover the expenses. So it is coming down, it will come down.
Yeah.
If we don't spend it, they just take it
And
back.
how last year? How was that? Was it decided in a different way, or is this a new way?
This is a new way of doing it. Before it was very ad hoc, didn't really work.
So that's what she
But
was
we just-
referring to. In
Exactly.
Yes.
That's right.
Okay.
Yeah.
And then the other one, which is just referring to staff, there's a large saving here due to the recruitment of permanent staff. What percentage do we have as temporary staff, and can we make more savings like this in the future years, which probably goes back to that conversation we've just been having.
So we spent about 13.6 million on staffing, and we had, I think, about 90 agency staff 2 years ago. Now we have 16 or 17, so it's come down, but it's all in line with our stats I gave you, the best in London for recruiting and retention for qualified staff. And we say more. I think we have. This is something is challenging, so that's what we are measured at push, which is 500,000, and then for 26-27 is 288. That's the maximum we can do. So we don't want to put anything which we can't deliver or impact on services.
Mm-hmm.
And also we don't want to do the three things we look at it with no disruption to service delivery, no redundancy, which is costing, and also and the other one is
Because the redundancies can be demoralizing as well.
So the other one is about retention, is a reputation as well. So that's the only reason we've done that.
Well, then,
Yeah, so one of the reports, not this one, but one of the other ones that we're looking at this evening does talk about significant ongoing gaps in the social worker workforce and the social care workforce. And I just wanted to get a sense of what that actually means. So of all the kind of social worker posts that exist at the moment, what proportion of those are unfilled?
Yeah, I think that is correct. There's a national shortage of qualified social workers in the country, and also OTs as well. But we have managed to recruit social workers apart from the 16 agency staff, and there may be various reasons for that. They are agency staff. Our aim is to reduce the number of agency staff, because I can't sort of give you a figure that we're going to reduce to 10 or something, because sometimes you need.
I was just wondering what proportion of the posts are unfilled at the moment, because I don't know what's significant.
Yeah, I would say about 10 staff, but they are not all of them are social workers, and most of them have been, the duty process admin staff or transformation manager.
Okay, so there aren't unfilled social worker posts.
I think maybe one or two, maybe they're unfilled.
Okay,
But there must be a reason why we not fill those posts. But most of those posts are going to come from the 500,000 savings is mainly based on transformation managers, and like I said, through 0.35 OT post or 0.25. For some reason they were in that establishment, so those posts will be.
So the significant social care gaps, posts being unfilled that's mentioned in the transformation report isn't correct.
So that's a national.
Right. Okay. All right. And the social service customer service team. So that's a separate team. And who the additional investment for that's needed, that's spoken about in the grade proposals, where does that come from?
call handlers, the people who answer the call.
Sure.
And they have seen an increase in number of inquiries because they fit to the referral and partial referral to the adult social care. And they have genuinely felt that there was some increase in referrals coming through. So therefore they need one course. So that's what the 40K is.
Okay. So the additional investment that's needed from that, where's it coming from? Because I think the report talks about that growth proposal. So where does the money from that come from?
From the general fund,
Just the general fund.
Oh, so it is council.
Yes, council money.
Oh, I
Yeah,
thought you said
sorry.
earlier it wasn't. Yeah.
No, it is
Okay.
from the-
Sorry, it's from council funding. So it's the call centre which sits under Johnny
Sure.
and Mike Curtis. When people call up, there's more people calling for adult social care needs.
Yeah.
They can't afford it under their directorate. So they put a bid in for our kind of general fund costs. We've given them 40K in order to fill that post.
Yeah.
It's just that the post isn't in adult social care direct.
Yeah,
Oh, I see.
exactly. It's just money.
Yeah. We had to bid for it because it's before adult social care, but
It's confusing. I know. It's just.
Yeah, I'm just trying to make sense of this enormous increase in demand that you're talking about, that's also coupled with some posts either being downgraded or unfilled. So just that's not computing.
Yeah.
Either what you're doing is, miraculous and needs to be studied by every other council, or something's not coming through in the reports.
I think if you see the increase in demand, it's not necessarily the numbers, it's mainly about the complexities and the cost of placements and the cost of home care, etc.
Well,
I'm not saying it's an easy budget to manage, but I'm saying it's a demand-led budget, which we have financial discipline, various measures in place. We know most of the budget lines and we have budget needs.
I don't think it's just about complexity. I mean, the report talks about a massive spike in referrals for care expenses, for example.
Yeah.
So,
But it's being managed. Whether
okay, all right, I'll take your word for it.
Okay.
Thank you, Chair. Just to touch on reserves, do we have enough in reserves to cover what we would think might be a worst case scenario for the next changes that we talked about earlier?
So the council itself has about 100 million in reserve now. That's got to reduce down. And for public health reserves, I don't know how much off the top of my head, but as I said, we can't keep that much in it because they'll just come and take money back off us, so we don't spend that money.
For 9 million.
Yeah.
It's ring fence.
Yeah.
But would that be enough to cover what, if we said before that if we don't get any extra money from central government?
So that public health money is not allowed to be spent on things like that. No, it has to be spent just for a public health outcome only. It's because the ring fence for that particular purpose.
So has any contingency work been done on?
Yeah, so the council need to really wait until the outcome of the local government finance assessment to understand the funding parameters. There will be a contingency budget built into the budget process.
And that's been done now.
Yeah, so it's being worked through, but again, it's quite difficult to make a
Yeah,
sensible
yeah.
contingency until we got facts, and that will come week commencing the 16th.
Of course, but in a worst case scenario situation,
I think it's a couple of million worst case scenario. The council would have solved for more. Again, those figures are still a bit of a movable piece, but I think the council will
just for
just for the next increase.
Yeah.
Oh, but just for the next increases as well. In general, it's a couple of million.
But in the stuff that in our department that we're focusing on tonight, what do we see the worst possible scenario increases impacting on the budget that you're managing?
I think the what we see is the 500,000 we needed, and we also know that the government has announced that 680K social care, that's about 2 to 3 million we will get. I think, in my experience, based on that, I don't think so. We will need more than 4 to 5 million, worst case scenario. But I can't nobody can predict how much is going to. You can give only the range is about 3 to 5 million, but that's again, we don't know the exact numbers. Nobody will know the exact numbers. It's based on hospital discharges and people becoming ill and all kind of. That's the nature of the budget we are managing. But the answer is that
Just on going back to mental health, is the reason why we're seeing this 12% rise because people aren't able to receive the type of care that they want from the NHS, so it's falling onto social care as a result of that. Is that what this spike is, or is there another reason for the spike?
I think you were right. I think it's one of the issue is that about going to hospital, vouchers, etc. So if you don't have inpatient beds, and that will have an impact on local authorities to support those people. The two things is support the people in residential care or nursing, and also is sometimes some people need to be in inpatient care to get better and come out and lead an independent life with the community care support. If that services are not in place at the right time, that is an issue that also impact on our.
This is why we need a decision on a future report that benefits our communities.
What was it? Adding to that quickly before we come to Jared, if, say, for example, we're told on Wednesday that we don't know if it's planned with decision, but that's sort of the MCAS will be taken away from St Charles. Does that impact social care referral costs too that we're not that we're kind of factoring into this budget? Or
Well, the hope is the MCAS will still remain open. I think that's the big thing, especially with the community concerns over Albury and North Kensington, especially the future of Tower, all that stuff. So we're really pushing that as a basis at least. Of course, they'll make a decision, as I said, relatively soon. But of course, if there's no service left provided by the NHS, people just come out onto the street and in their community and their homes that they need access for it, which we need to step in for. And of course, we're not really funded that way because we don't provide primary services. So it's
and legally we can't fund
and legally we're not allowed as a council to provide health services at all. So it's just very, very hard.
So do you envision that referral rates and say, for example, next year it's going to continue to go up? And how do we? I mean, are there conversations going on with the NHS as to?
All
the
time, yes. All the time. Yeah.
Every meeting, we raise it.
And I'm meeting with Penny and Rob, Chair and CEO of the ICP on Wednesday, to talk about this and other wider issues as well.
Just following up, more of a general question. Obviously, like us, like local government, the NHS is under equal pressure. Do you get a sense that, you must say sort of discharge, if they speed up their discharge and it comes to us and yet we have more costs because of, do you get any sense that the NHS can offset their cuts by loading local government?
I think when they started introducing something called discharge to assets, I think that was introduced 2 years ago. And we've seen, and you can see the spend that it went up, not just in our case, again, other councils. Well, discharge to assets means that sort of people are discharged somewhere to do the assessment.
Someone's got to pick that up.
Used to be fit for discharge, now it's discharge to assets. So that all has an impact on the local authority and the local authority and the social.
Is there any way of knowing, going forward, knowing what that is? Is it going to get worse? Can you quantify it? Or is it just you have to react to it when it happens?
I think that's where we are negotiating based on, we got this 1.45 million on discharge grant. So every year we will have to provide all the data and we don't get everything what we spend, but we get something negotiate to get some good settlement. So that's what we've been doing, and we're getting this. Last year we got that 1.45, I think. So that's the way we negotiate.
It wasn't just discharge, and that's the key one, but the other factors in it that it always seems that when other services costs in their end, it ends up on the feet of local government, and that can ruin a budget.
Yeah, that's why in adult social care world, it's about we want government to look at social care and healthcare together, one pot of money. If there is a block in the system, the other will have to compensate. So likewise, if people are not getting the treatment in the right time, like MCAS or the acute beds, that will have a short-term as well as long-term impact on someone's life, and that then we will have to pick that up. Yes.
One question, because I'm very curious. You know, when you have your conversations with the NHS about shaping service or what service programs you need to offer, who is at the table making these decisions and negotiation? And where do you get your data from? I mean, where do you get your input from? Is it from residents, or is it just your team, or is it staff, or is it councillors? Where do you get that information from?
It comes on our, just to answer as well, in his level, in his role. But in the officer level, that we have various, ICB partnership meetings and various board meetings, various strategic meetings, operational meetings, and the people who deals with data, they share data. We also have health and wellbeing board, and there we have representations from senior officers from the ICD as well as trust.
Residents come.
And also residents, all sector, voluntary sector, etc. So it's a combination.
So it comes from my position, Portia, as well. It comes from a range of things. So this committee as well, members writing in. So I do get a lot of members' correspondence from all the councillors raising issues and concerns. As well, we have when we go out and meet people as well. So when I go meet ADKC in North Kensington, or people MENCAP exactly, or visiting other service users, St Charles Hospital or Chelsea and Westminster. When I go speak to staff and patients there, we kind of get people kind of feeding in on this information as well. Like this says the Health and Wellbeing Board, which I chair with Councillor Batman in Westminster. We have residents come to that as well and read any concern they may want to have for the relevant NHS people at the board at the time as well. But the thing is that we always need more information to come into. So not everyone always knows what to come or what to raise or issues like that. And of course, I think yourselves as committee chairs too will also receive information. I know Lucy, you do as well as your chair, through other people coming to recruit you as well, and how that all kind of feeds back into our meetings with the ICB as well. To it, there are some things that we don't get right. There are some things that they don't get right. It's just trying to figure out that the best way we can as well. But I think officers obviously conversation with them every single day. I'm obviously more from the top level every so often, but trying to ensure that constant stream. So if you have any reviews or suggestions or resident feedback or something not working somewhere, obviously just flag it up and it will trickle its way back up. So, yeah.
Thank you. Thank you. Any further questions in the feedback? Yeah. Moving on to sorry.
Other councillors?
Very sorry.
I was just thinking that, my first comment is that we've discussed contingency, and I'm sure you'd already thought of this, Chair, but maybe there's a recommendation that, given the discussion we've had, now contingency is held centrally and not at business group level, quite rightly, that is enough information going into calculating what the central contingency should be, given the concerns that we've voiced tonight about whether it's sufficient. And also we'll be having the same discussion in adults, in children, I imagine, for the same reason, that sort of the odd case that costs $500,000. So I think it might be worth recommending that some transparency on how the centrally held contingency is funded and whether it contains enough depth for both these business groups. But I had a couple of questions. One is there seems to be no growth and no savings on public health. Is that absolutely right? Is there no change of activity at all?
I think the public health is the grant, and there are specific requirements.
But our spending, I can see that the income grant is the same, but on our spending, for example, I mean, are we not saving on letting contracts, for example? But
yeah, there are contract savings that's being reinvested in the area where we need more services, or then most of the time, because of the inflation, etc., the contract price is going up and up. But we are always Anna's team is reviewing most of the contracts and also reviewing most of the services to find efficiencies.
Yeah.
Because we cannot call our savings in grant, but that is an ongoing process, and we will continue to do that.
I'm just surprised that there's not, any change of, spending worth reporting in this committee. And can I just ask about two savings, Chamberlain House and Reablement, both of which are really vital services.
Yes.
And we're saving 100,000 on each. For example, on Chamberlain House, we are saving on travel and staff.
Yeah.
I'd really like to be certain that those services are still going to be safe and also respond to the needs of their clientele.
Yes. I think is we have already done some soft consultation with the residents there. It is in St. Charles.
Yes.
It's not a.
I've visited it many times.
It's not a great building for it's an old building. So we would like to move them to a more suitable building.
Still close by.
Close by. And also it has to be better than what they are getting now. So I think there's no ducting in any service in there. In fact, it will be much better place. And also the main reason also the St. Charles in rate is significant increase they're asking, which we don't think that's value for money.
So you're convincing me that the service will be as good, if not better,
Yes.
despite staff savings, but presumably the rent saving and the reablement.
Yeah.
I can't quite. I mean, again, that's really key to the service that we provide, and also moving people out of hospital quickly.
Yeah, but you may remember that we had an in-house service, and that then we brought in specialist care providers to provide. So those savings. So we achieved those savings, and we have 100K already achieved. So this is kind of straightforward savings.
Okay. This is banking and a saving already. Okay, thank you very much. Sorry to.
Thank you, Mary. I think Mary is really very good point in terms of her recommendation, if we're happy to agree that one. May I also,
Repeat the wording.
Mary, do you want to say it once more?
Again, the word.
She caught me on the hop. Just to recommend, in the light of the unpredictability of the individual case costs, both in adult social care and children's, that the contingency budget be reviewed to ensure it's sufficient, or that we receive satisfaction or confirmation that it's sufficient for this budget, as we don't have our own contingency.
Yeah. Does anyone else want to make any other recommendations to it? Jared, do you want to?
Well, just I don't know whether we can make it into recommend. In a lot of these savings, there are costs going to be incurred to make the savings. You talk about specialist equipment, that is going to be presumably an additional cost, which will feed back. So do we need a bit more clarity on the costs of some of these savings, if you like, and how that cost is rolled into the actual saving? So you look at, for example, the other one you talk about, Kingsbridge Road, and in Shortbridge, it looks to me as though there's going to be a cost to achieve that. So do we need some clarity on?
Yeah. You've got to work in the capital cost for about £400,000, but that's in the capital work. The bit was going to have a long-term saving through the general fund.
Yes,
Yes, that's right.
So
I appreciate there is, you look at lots further, that's capital.
That's right. Exactly.
Looking at some of these, there are general fund costs as well.
Yeah.
for the equipment will again coming from a grant called BFG, disability. Yeah, the DFG is a disability facility grant. As part of the BCF, we get that money.
You just mentioned three initials there that have exactly what you're talking about.
So the BFG is disability facilities grant. It's part of the BCF, Better Care Fund. So in other words, it's government grant,
right?
Which you can use it to pay for.
So I think some reassurance that there are grants coming in that will help us, like the discharge grant, that will help us offset those costs.
Thank you.
Thank you very much. Thank you all. Moving on to agenda item 5, which is policy repair and transformation. This report provides detail on the transformation program undertaken by the department to navigate challenges in the delivery of services and continue to deliver good outcomes for residents. The committee is asked to consider how the directorate can maximise the impact of future transformation. I think we have Josh and Karen. Thank you very much.
Thank you, Chair. I won't introduce the report too much because it's only about 2 pages, and it does what it says on the tin. But this is just a very, very brief overview of our transformation program. The adults in care, I know Moni referred to it earlier. You may have some other questions on this as well. But just go through kind of some of our ideas, our workforce, our building the care market, and some of our kind of technology improvements we've introduced, such as the virtual wallet, things which have become very successful, and how we can kind of make that better and more accessible for those using it. But really.
I suppose only to say that the transformation is sort of a term of the day, isn't it? Transformation work happening in different sectors, and some councils will have in adult social care and public health a transformation team that helps them kind of go through these sorts of processes, or like bringing an external consultancy to kind of work all that out for them. I think part of what we're describing, actually the previous item that we've talked about quite a bit, but also in this report, is we do a lot of this ourselves. We do look at best practice elsewhere in the sector, but mostly this is about incremental change to deliver what might be described as transformation for us in relation to those areas that Josh described.
Thank you. Thank you very much, and thank you for the feedback. I think the only thing that I'd be really interested to see is just how, in terms of what other boroughs around the country are doing in this area and how we compare, and are we leading the way or looking to do innovative things in the years to come that maybe other councils have had huge success on. I don't know if you have anything to add on, or maybe in future reports when we look at this, it'd be good to be able to.
The one area that I think really has scope for us and other councils to do more, and where some councils are already doing a little more than us, is in relation to technology-enabled living and kind of digital work in general. So technology-enabled living we talk about particularly in relation to assistive technology in people's homes, bits of GPS devices, monitoring sensors, some of the things that are described in the paper. That's a growing market, and as that technology grows and people's comfort in using those sorts of tools in their own homes grows as well, which we anticipate, then absolutely that's something that we would expect to see a growth area of things. What some councils, as described in the paper, our approach to that has been there's kind of a baseline of what we offer in terms of particularly sensors and some sort of omniscient observation, so we can tell us something's changing. And separately, we've run, I think I might have described this here before, we run sort of 2 or 3 a year, these sessions called Assistive Technology Dragon's Den session. We get called all the time from different companies saying, we've got this great new bit of kit, and do you want to try it out? And so we wanted to try and find a way to control that. So we host these, we invite 10 providers to come along, pitch their way, a bit like a Dragon's Den on the TV. And they do that in front of a group of service users, including some people from our local account group, professional social workers, and some commissioners as well, who ask questions, etc. And then if any of them look like they have a particular interest or a particular benefit to us, we might pilot them for a year or 2 to see if they're right for our areas. That's quite a slow process compared to it's worked in quite a few of these instances, but it's actually kind of quite a slow process in terms of the volume of activity there is out there in the market. What some other places have done is to kind of set up a whole system with a third-party provider that manages all of that for them. And they're a bit like the way our community equipment service works, actually, with kind of different products on the shelf. There's a catalogue of them. Every time somebody's prescribed, this organisation goes out and it's installed in someone's home. What that I think might change for us in future in terms of transformation is the kind of the awareness and the skills and capability, I suppose, in terms of understanding what those different bits of technology on a catalogue can do, needs to be at the fingertips of social workers and occupational therapists.
Yeah.
Rather than having a sort of ghettoized tech team over here,
Yeah.
It's really important that we create the tools to make it day-to-day business for social workers and OTs to be able to do that. And that's some places that we've talked to have started to move their resources in that area around learning and development on tech for professional stuff. And that's probably one of the biggest shifts in that.
But I think this council is not very good at all really on technology or information or in that regard. I think Gareth and the team have done a good job as examples 7, Dragons Den thing, in and room for this council.
Yeah.
But I think overall, we certainly need to do better. I think.
How? I mean, that's very honest, but how?
No, it's
how,
true. No, that's
how
good.
do we,
Oh, we
how do
have.
we change? Because I mean,
Yeah,
surely
yeah.
this is an area where
Yeah.
we can not only be thinking kind of future savings,
Yeah.
but also
No, I agree, Chair.
impact.
And for social care, I think we're
In a good way.
we're kind of
aligning
doing
those.
things in a good way overall. We've got not very good website. We don't have very good, IT, all that kind of stuff.
Yeah.
I think everyone knows about the issues that we have. But yeah, it's certainly something that is a challenge for us to recognise and do in that regard. And I think, as I said, Gareth's got some really good ideas.
No, I think the Dragon's Den.
And I think about RB. The thing about RBKC is, since we're such a kind of a flagship borough, central London, people do come approach us, which many other authorities won't have. So we do have kind of a benefit of that. We get the name recognition, perhaps other places don't. So it's just taking advantage of that as well.
And are we looking at sort of other boroughs, other countries, or what kind of tech is transforming?
Yeah, we do on a regular basis. We've got a kind of adult social care digital leadership group moving forward that includes those staff that are involved in the digital inclusion work, people from IT and digital teams, but predominantly adult social care. And part of what they do is keeping up with what's happening in other councils. So not just other London boroughs, but particularly county councils seem to be able to forge ahead with quite a lot of this. There's some interesting, really interesting work happening in Essex and Norfolk. The teams that have been in touch with recently, and they've come to present to that group about how they set some of these arrangements up, a bit like what I've just described. We're also working with, there's a group called the London Office for Technology and Innovation, Innovation or Information, LOTI, called, which I think is set up by the GLA. And part of what they do is it's like a kind of kite mark assessment for different business assisted technology that come into the market. So as boroughs and as local authorities, we can look at that and say, okay, like this group have looked at it. We know that New and Brent and Lambeth are using it, and they've given it this sort of view, a bit like check and trade. That kind of type of system. So you can see the case study, what it's like, and whether it's maybe something that we want to take an interest in. So there's a helpful third party body doing that for us. And yes, like some international work too. So where particularly obvious candidates from places like Japan, Germany, there's a lot for us to learn from both the actual application of types of technology, but also kind of generally dealing with aging populations probably in advance of where we are.
So I guess 2 questions. Firstly is just on that last point, really, what are we doing to learn from places like Japan? I mean, are you in touch with, for example, local councils and preferences out there and people that run them, or is there some sort of organised effort by local LGA or local government bodies, London councils, to try and build some sort of relationships so we can do that? Would be my first question. Second, just in case I forget. Are we seeing much in sort of Dragon's Den and things? AI, is that coming into use in a lot of these new technologies or people pitching new business?
In terms of Japan,
but all other countries,
yes, but particularly Japan, there's a wonderful organisation called the Japan Centre for Local Government, which is I think still based on the Strand, funded by the Japanese government sits in the UK, and it's basically there to kind of proselytise about Japan does this sort of stuff, and so works with local authorities and funds a trip every year to Japan for up to 10 local government officers and councillors to learn from how about how Japan understands and Japan does these things. And it's on a different theme every year. So sometimes it's about economic generation, etc. But they've done quite a few on this particular topic. And so we've talked to colleagues and other local authorities who've been on those trips. And part of the deal is that bring it back and spread the word. And so there's a kind of ready-made mechanism for doing that in Japan, less so Germany and the USA, but we do the usual thing you would do for this, where there isn't a ready-made unit like that. We're working through trade press, sectoral interest groups, conferences and events that we can get to or get materials from to make sure that we're keeping up to date with it. But yes, I can share the details about the Japan.
Has anyone from RBKC gone?
Not to my knowledge, no. But a colleague I used to work with who is now in Essex County Council did, and we invited him to come. He told me a great story about technology in Japan, where they have, you might have seen in the press release recently, AI pets that are helpful for people with dementia, memory, cognition issues. The really well-known one in Japan is a seal that people have, and the reason they chose a seal is because no one's had a bad experience with a seal. Whereas if it was, people might have been bitten by a dog or lost a cat, so it would be upsetting for them for a seal. It's really popular. On AI, so some of these products that we've been talking about at Dragon's Den have a bit of kind of AI wash to them, if I'm honest. It's sort of in everything. Some people are talking about AI these days. The pilot is the way that's probably closest to us using it. Is a tool called Magic Notes. So this is more for staff efficiency than it is for products that might be used in people's homes. And so Magic Notes has been trialled in quite a few councils. We've been approached the company to come do a demonstration for us. Effectively, it's an AI tool, a bit like Copilot that Microsoft has, ChatGPT type things, where if a social worker is taking an assessment for somebody, it can transcribe their notes and help to summarise and build them into the starting points of the care plan. Clearly, as the human checks all of that, but it's proving very popular and effective in places where it's also.
Are we, if I may, Chair, are we looking at anything like that?
They've been in to do a demo, both for children's and for adults, and they've just submitted a cost for a sample trial for a certain number of licenses. So yeah, we want.
When would you be deciding?
We've got to decide that this week, according to yes.
What did you think?
Yeah, sorry, it's not nearly as interesting. It's about out of area placements and just the focus on building the local care market. And I was wondering if it would be helpful just to quantify, just in terms of thinking about the numbers of those individuals who are placed out of area, and excluding those who are placed out of area because there just isn't the specialist housing that they need in borough. And if there were any sort of in the best case scenario of what we were aiming for, who would we be, like, what is the population that we'd be wanting to repatriate if we did kind of manage to achieve these points in 5.6 and build the capacity for.
Just to understand your question, is it what's the realistic picture? 45 more.
Yeah, I mean, and out of those,
it's 45. We currently have 45 people outside of borough.
And are they happy there, or are they opting to be repatriated?
Yeah, it depends on the individual. What we're trying to do with what's listed here is to bring them back. Some people aren't close to their families, for example. Some people are just living, as we've said before, some people live as far away as Scotland. It may not be best for them in the long term.
So inexpensive placements for them.
No, that's actually that's the thing. So it would be actually cheaper for them to come back in borough.
Yeah.
But obviously, putting them in places in London is still more expensive than other places as well. So if we were to build capital works here, which we've got here, St Helens Garden, Kingsbridge, Lots Road, which I mentioned in the previous budget discussion. excluding the extra care, which is 65, we currently have 45 people outside of borough, but yes, they will ultimately come back in borough. Mostly people with learning disabilities, and what we're seeing in the learning disabilities area is actually getting an increase of people over the age of 65 that need homes and care, because I previously they lived with their parents, and unfortunately their parents have got 80s and 90s and have sadly died. So, you know, they need to be homed, housed somewhere in the borough the best way we can. So this is the kind of the vision that we would ideally like to do for that. It will have obviously a capital cost to those situations, but as I said at the start, we have not, since ASC have not really built anything in 10 years in this borough, transforming that kind of mindset amongst the team in order to ensure that we're kind of a capital building, you know, work hub, so people can come back and live in the borough where they grew up, where they belong.
And is that an aim?
Yes, absolutely.
Okay.
Yeah, definitely.
With a view to build how much in terms of housing?
So overall about 60 new homes for people with adult social care or learning disability needs, excluding the 65 extra care units, as I said, but we can add them on as well. And they will be all across the borough. So, for example, about 7 in St Helens Gardens, about 11 in Kingsbridge, 65, I mentioned 22 potentially in Earls Court. You know, all these things are not yet decided, but that's kind of the aim that we're working towards to get these done.
Okay, and sort of how hopeful are you that you'll be able to have capacity
Yes, that's a really
from
good question.
things like Canal Side or
Yeah.
Lots Road?
So Canal Side is obviously not our development. We just have to work with what Ballymore,
Yeah.
you know, we're really kind of holding them to account because of I don't know, issues with the site and logistics and everything, to get the best possible we can get for that. Some of them are closer than others. So like St Helens Gardens and Kingsbridge, I would say the next, as you know, 2 to 3 years. Lots Road about 28, 29, Gareth, I would think, for the 65 extra care units. Kensal and Earls Court, you know, they're very long-term building works. So you're just working with them the best way we can. See,
How will that be staffed? All these additional sort of close to home places?
So the business case for that rests on this analysis we've done that shows that it's cheaper to run services than elsewhere. So in following up on the points that was in the budget, at the outset that will require some investment savings input. So we may ask for growth for a few years while we get the place up and running with a provider that will go to market for. But the kind of benefit of that is that over a period of time we're spending less on delivering care locally with that care provider than we are externally. So the kind of the outline business case of proposition stacks up on that basis. The other point I've just added, if I may, is Josh is absolutely right in terms of the commitment that the council has given to developing more adult social care quality. There's also work happening between our teams in the housing to make sure that we can access more general needs housing for people with moderate adult social care needs, and where necessary they can be adapted to do that, because we haven't really been making the most of the potential nominations we could have in general.
Yeah. But this is my big push for the last 18 months I've been in this role, is to really get this kind of out there and done.
Yeah, and I think it would have a huge impact on people's
absolutely.
lives. It's set in the middle of nowhere.
I've just got a couple more questions. Firstly, just in terms of just understanding, I don't think you've had any, you're saying you don't have any complaints of sort of digital transformation, and it's very much up to the resident what gets changed and if they kind of move over to more.
For some people, you know, are still digitally excluded, so we want to ensure, you know, they are pressured to do something that they're comfortable with as well. You know, very few of different ages, I mean, and different skills, so it's no kind of you know, we're very aware of that's, you know, it doesn't work for everyone, and we try to do our best to work around that the best way we can as well.
I was more interested with those who've decided to kind of take the plunge and do a bit more or trial it. Have they, most of them, enjoyed it, or what's kind of been the feedback that you've been getting with?
Most people have stuck with it, and some of the ones that we mentioned here, so Brain in Hand, for example, some people have really taking that on board as part of their daily life. So one of the things it talks here about a traffic light system, actually, in terms of how are you feeling today. One of the really practical uses it has for people, particularly people who are autistic, is there's often kind of really good training programs in place to help people get from A to B, make use of public transport, get around. And then when something goes wrong with public transport, as it often does, the bus is cancelled, the tube line's down, and that plan goes awry, it can be really distressing for the individual if their expectations aren't there. And what Brain in Hand does is works with those individuals to say, okay, let's make a plan in advance about what happens in those circumstances. So if you find yourself at a bus stop and all the buses are cancelled, here's who you call, here's what you can do. And so it kind of acts as a tool to support people to live independently. And quite a lot of these have really taken it on board on that sort of basis, and in fact work with the company to find other ways to do that. And for others, it's kind of dropped off. So it really is about finding individual preference. Similar with the virtual wallet, that's effectively an online bank account system for people to manage their direct payment. Some people just prefer us to make the arrangement for them, and the technology isn't really the thing for them. But in some circumstances, particularly where there are family carers involved, where somebody might have power of attorney, having a really simple system where all of the family, if they're dispersed around different parts of the country, can see how that money is working, it's actually really helpful. So it's the general rule of thumb in terms of interest and adoption is about a third of people we engage with are really interested and want to try something, and a third are curious, and a third don't know.
Yeah. So you think year on year that kind of take up might?
Yeah, I think that third we don't want to know which group.
Yeah.
Yeah.
And then the other last question I can ask Ms. Jarrett is just you speak about at the end of the report how you could maybe use data better in terms of transformation, so just understanding. I think that's the way I found it. Should directors approach to making better use of data by automating data reporting and management processes, just sort of what you're doing, trying to do that in the next year, and whether there's more opportunity to be sharing data with the NHS or.
That's a separate point. I'll come to that. But I think just in terms of our own data, we use a database for care management called Mosaic, which holds all of our information about service users. And we have databases of information with our external providers too, which interests some of those interact with the financial systems. We've got a really good business analysis team. But they're small. And I think we're all really mindful that there's a lot of richness in that data, that data sciences have advanced in a way that we haven't really been able to take advantage of yet. So things like predictive analytics and being able to use what we know to forecast when things might change for people better, so that we can put interventions in place, do more of that prevention work that Liz was talking about. I think there's a rich scene for us to get into there, and at the appropriate point when we've got the resources to do it.
Do we have any data science resources in the council?
In the digital team, there are some. We have people in our team who are data scientists, but they're generally focused on specific areas. There's something like the really complicated analysis there is in relation to alcohol and substance misuse, for example. We have a data scientist that works on that because the grant we get says we have to do. But you can see somebody with those sorts of skills set out. So find a way to apply that here at the right point. In relation to sharing with the NHS, yes, we do a lot of that, and with other partners too, including Met Police, probation, etc. But with the NHS in particular, we're really careful about our mutual obligations for using data in the right way. Some of the called guarding for adults, which means I've got a role to make sure that data is used safe in individuals' interests. We're very well managed, respectively, in terms of rules-based access to data. So only our social workers are accessing particular types of information from the NHS. Because there's real concern about benefits officers using that, and similarly the other way around. So it does work. There's probably room for us to do more of that in future, particularly when we get to the idea of one care record for London. Some of our providers having access to that too. But it's definitely an improvement space.
Okay.
Thank you. I mean, reading this report, there's a lot of exciting stuff in it. Can you give us not in this report, but future, some more stats? How many people use these? What's the impact been? Just a bit of information that would help us understand the magnitude of it. And secondly, can we have an opportunity to see some of these things in action?
Yeah.
Because there's some quite exciting stuff there.
Yeah,
And it would help me get a feel of what this stuff is doing and more to the point, impact of it on people's lives.
Yeah, it'd be great to do that.
That's good idea, Jared.
Don't expect us to be too techy.
I think also, I mean, I find this all really interesting and talking about what sort of Roberta and I was speaking about at the start, but just understanding if we are maybe not great at
The council as a whole, I'm saying, Chair.
being ahead of the game here,
That's right.
how we're sort of really making it a priority. Because I think so much can be gained, not just for residents, but also maybe potentially in kind of cost savings in years to come by putting this front and centre.
And examples of boroughs that really are ahead of the game on this. And,
Yeah, I think that would be really interesting to see.
Yeah,
Is
yeah.
who's leading the way? Probably the best benchmarks about against UK boroughs or counties, but just I don't know if there's kind of news headlines of certain things that are working in certain places and what we could be now.
Yes, I just wanted to comment. I was a bit surprised that technology as a sort of tool of productivity didn't get a higher sort of profile in this paper. In fact, it took Roberto to ask a question about
Nothing's bad then.
which clearly is an indicative of the depths to which we submit. But you know, technology enabled living is great, but what about with our own workforce and using technology to increase, for example, to save social workers time in writing reports? Well, you mentioned letters, but I mean that's kind of fairly basic stuff. It would just be nice to know or to be reassured that we are using technology to drive productivity and to enable our workforce to do what they're really good at, rather than doing the boring jobs behind the scenes. Is it true to say that you are doing that, just didn't make it into the report?
Yeah, but apologies, that's not written large in the report. Thank you for the question that now been talked about magic notes as this new example of something that we're testing. But I suppose as with other departments of the council, we're making the most of working with Digital Data and Transformation Directorate, which covers all of our IT in terms of new things that could help our teams to be as efficient as possible. And that includes using Microsoft Copilot, which again is kind of an AI tool that helps them to work more efficiently. Actually, all the kind of hardware and mobile devices that staff have, which means that they can work around about the borough and in people's homes and do their work there and then, rather than to come back and transpose things on the back.
No, and it just seems to be a fundamental part of transforming the way we work as well as the things we do with our clients. So it'd be nice to know that in the coming year it's got a high profile.
Yeah, it's very funny. Any last minutes? Thank you both so much. That was really interesting. Moving on to our work programme reports. This report sets out the development of the Select Committee's work programme, identifying priorities for the next year. Does the committee agree? Right. So the meeting is
so the next meeting is
next meeting is 6th February, and because of the consultation that's happening around palliative care, James and I said the other day, and we were thinking whether to basically do a session on palliative care, because it's just before it will be making the decision and the consultation will be closing, if we want to kind of have the right representatives here to talk to them and kind of raise the profile of Pembridge. So I don't know what people's thoughts are on that.
Add it to the agenda or?
I don't know the background on Pembridge, you probably don't. Yeah, I think also that Stephanie and Roberto will going to have that context. So
yeah, I mean, just to say, Councillor, the documentation, because it's a public consultation, is quite substantive, quite substantial. So it will be quite a lot of reading. So if you add it to the existing work programme, the items already on there, would be a very, very busy meeting.
So which would be the proposal to move off?
Yeah, so it's just a suggestion, so the committee's still agreeing, but you could slightly flex the programme so you have hospital discharge and screening outcomes in April, and you focus on others of care at the 6th of every meeting.
I worry with that is hospital discharge, that is some of the worst months, kind of winter time, that we're kind of, I don't know. Is it a risk taking that and leaving it to April then?
But it could be a risk, but is there anything we're going to be able to do with that then?
Yeah, exactly.
And then you'd move the April meetings to the next meeting in the next.
We've got a very, the April meeting.
It's quite a capacity for April meeting.
How are the options?
Yeah, and also because the consultation ends on the 24th of February. Reviewing it on the 6th of February is actually really private, but it's actually very good timing to get on.
Sorry, say that last bit again.
The public consultation council ends on the 24th of February.
Okay.
So you've got a meeting scheduled for the 6th of February. So that's good timing in terms of being able to review the proposal.
And we also want to hopefully make a sort of give right into the consultation as a committee, but I thought it could be worthwhile to have the meeting and then we make.
Yeah, and then on the basis of what's said at the meeting, your conclusions, and that could be part of your response in terms of formal consultation.
Yeah, one of the options in the consultation is keeping is reopening the Penn Bridge, which has been ongoing, sort of similar to the Gordon Hospital for how many years? Like 4 or 5 years.
Longer than the Gordon.
Yeah, much longer than the Gordon. So I think it feels an important time to be having a.
You made a case.
Have I made a case? I don't know what everyone's thoughts are.
It sounds very sensible. My only thing is in the April meeting, you've got 2 meetings here and you're going to merge them into one. Would that not be too?
Or need to probably take them out there.
Well, that's what I'm saying, is that I'm all for with palliative care. I just one particular category, but moving both hospital discharge and cancer.
What is the update on the suicide prevention?
Well, we're ready to go with first session, which is going to find a date.
Okay.
Which I know I have said before, so apologies.
Yeah.
But we will be starting that in early in the year.
Yeah.
So that's outside of the
Like
meetings.
Yeah. Okay. So is that standing as a report there?
Well, that could be moved around as well.
Okay.
To June or July.
Yeah. So a little bit later.
So if we had housing options and then we moved those 2, so we would be having 3 reports in April, do you think those 3 reports are manageable on meetings?
3 is probably about the upper limit.
What is that?
It's manageable.
What are the 3?
It would be housing options, cancer screening and hospital discharge in April, and we could shift the
suicide gets moved.
because the prevention group is going on anyway outside of this committee, so it's the kind of final report that could be and then we choose the February meeting to be solely based on the Pembridge.
Is there any other subject in the April meeting that could be tagged on to the end of the
Yeah, that's true.
Cambridge, just something less meaty?
James, what do you think?
Just because all 3 of them look really important.
How big do you think? How big is the reading? I mean, I'm just imagining it's going to be something like what we read for the Gordon Hospital.
It will be, yeah. So they've done their pre-decision business case and they've got their consultation document. So it's going to
Will be like that big.
It'll be really big.
It's going to be substantive.
Whenever we get it, we'll have to.
I think it would be a loss not to have them here
It seemed perfect timing. It was eminently sensible.
because it's been such an ongoing conversation so long. Well,
Can we suggest the that's what we want to do? You juggle
work
around
on-
with
we
some
can
of the others, and
tag
because
on
you know
everything else.
how big the reports are going to be and that sort of thing. So
This is also whether.
So you want to agree to do the
palliative care.
palliative care in February, and then the rest of the work programme can be worked out
Yes.
as an action.
And if there's one that could be, that's on the slimmer side, that could be added to that meeting time wise, that could work, then to add that so that the April meeting's not so lengthy, but if not, I guess we'll just have to eat before we sit down.
And that we are moving the suicide prevention to June, July.
So that is a working group, so the final report would just be moved in terms of when.
but just to make sure that that's.
Yeah.
Agreed.
Is that agreed quickly? All agreed to.
Are we quorum?
I think that ends the meeting. Ends the meeting.
Yep. Good, thank you. How many do you need for quorum?
Mary, sorry for missing you first.
I know you just.
No, I was.
Elizabeth does it to me every time.
I said, oh,
We're going to do specific